Thank you, Johnny, and thank you for sticking around. We've heard a lot about cystic lesions, so we are moving back to a solid tumor mostly. So you can see these tumors arise from the Atwood cells and account for about 1 to 10% of neoplasms. And there's equal frequency in men and women. Peak age is usually much later in life. And they can be divided broadly into functioning and non-functioning tumors. There's increased frequency of the functioning tumors and the non-functioning ones in patients who have certain syndromes, such as MEN1, von Hippel-Lindau, neurofibromatosis, and tuberous sclerosis. The non-functioning tumors account for about 15 to 13%, and these numbers vary depending on which series you read. In some numbers, it's higher. I'm going to begin off with non-functioning tumors because there's been some change in the last decade or in the last 5-6 years about their management, which I'll focus mainly on. So non-functioning tumors are slightly more common in women. They are sporadic, but also can be seen, as I said, in patients who have certain syndromes that we mentioned. And for a long time, when I was training many decades ago, all we saw was these huge tumors which had already spread, and the patients usually were symptomatic because of the large size of the tumor, pain, weight loss, etc., and rarely jaundice depending on where the tumor was located. And the average size was quite large. As you'll see in a few minutes, we are starting to see a different type now. Metastatic disease was fairly common. It's been reported in up to 60 to 80%. That's still somewhat true. And although these are non-functioning or silent tumors, they are just not overtly hyperfunctioning, but do secrete hormones. So, for example, if you estimate serum chromogranin A, all of them are elevated in these patients, and as well as the polypeptides. So this is the type of tumor we usually saw, at least when I was a resident. This is what we saw in a non-functioning tumor. A large tumor in both on CT and MR. You can see involvement of the tail of the pancreas with large metastasis with areas of necrosis and degeneration. And that's what we were commonly used to seeing. But with the widespread use of cross-sectional imaging modalities as well as our improved accuracy, we are starting to see small incidental sporadic non-functioning tumors a little bit more commonly. So in one series, for example, this is now like 35% of PNETs were sporadic and incidentally detected. And that's what I think we are starting to see in our practice, contrary to what we saw decades ago. And if you look at some series, the incidence of malignancy among all these small tumors, smaller than 2 centimeters, is quite low. It's around 6%. But alarmingly, liver metastasis occurs still in about 30% of patients in even these small tumors. So it's a little disturbing that you see that like that. Here's what we are typically seeing more often now, the so-called incidental tumor. In a patient who comes for some other reason, we do a CT scan, and you can see there's a very tiny, small hypervascular lesion. It's masked in the portal venous phase, but you can see it's well-defined, it's homogeneously enhancing. So that's what an incidental, well-differentiated tumor looks like. Here's another one on the arterial phase, and then on the portal venous phase, and one of the hallmarks is, in contrast to, for example, a pancreatic adenocarcinoma, this will remain somewhat hyperdense even on the portal venous phase, whereas typically PD, pancreatic ductal adenocarcinomas, are hypovascular or hyperdense lesions. The classification is based really on size as well as biopsy results, where we look at mitotic index or mitotic count per 10 high power field and the Ki-67 index. And you can see the well-differentiated tumors are small size, have low mitotic count, low Ki-67 index when they don't have angioinvasion or metastatic disease. And as you move down the scale to more poorly differentiated endocrine carcinomas, you have bigger size as well. You can see greater than 2 centimeters. You can see that the mitotic count goes up, as well as the Ki-67 goes up. Is there a correlation between imaging appearance and the tumor grade? Small studies suggest that there may be something to this. For example, the well-differentiated tumors are smaller, they are more hyper-attenuating on the pancreatic phase as well as the portal venous phase, whereas the G2 and G3 tumors were larger than 2 centimeters and did not have these features on the typical phases that we use to study the pancreas. And so they suggested in these two studies with small numbers of patients that the more advanced or more high-grade tumors had low arterial enhancement ratio when compared to the G1 tumors. So they suggested that MDCT contrast-enhanced features may correlate with histopathology, and that's what people are starting to use now. Here's this from their paper published this year in Clinical Radiology. You can see a small hypervascular tumor, hypodense on the portal venous or delayed phase. This was a G1 tumor or a well-differentiated carcinoma, in contrast to this lesion, which doesn't show typical vascular enhancement, and you can see the patient has a liver metastasis, and this is a slightly more higher grade tumor. So based on imaging appearances, it appears that in small series that we may be able to predict tumor grade. This holds true for MR as well. There's another paper published this year, 49 resected tumors who underwent MR. They looked at all these features that are listed over here, and you can see that their conclusion was, in general, lower grade tumors were smaller in size, more well-defined, and showed homogeneous enhancement with contrast, had low DWI and higher ADC values in comparison to G3 tumors. Examples, here's a G1 tumor, a very small tumor. This is the same patient who had the CT, T2 bright. Here's the DWI, showing you the tumor nicely. Arterial phase, diffuse homogeneous enhancement, a low-grade neoplasm. This is from the literature that I quoted. This is a more aggressive tumor. You can see it's low signal intensity on T2 weighted images, shows not the typical hypervascular homogeneous enhancements, more heterogeneous enhancement, obviously larger size than 2. Here's the DWI and low ADC value correlating with an aggressive tumor. And I already showed you this example of a large tumor with tumor necrosis, again showing heterogeneous enhancement and not homogeneous enhancement. Moving on to nuclear scintigraphy, FDG PET is not very good for detection of these tumors or the metastatic lesions. Indium octreotide, which we used to use in the past, you guys are way ahead of us in moving on to DOTA, dotatate octreotide, but the old agent had only a 60 to 70% specificity, in contrast to the gallium DOTA agents, which are showing greater affinity for NET and greater than 90% specificity for diagnosis. This is from the literature published in 6-7 years ago, showing neuroendocrine tumor comparison of FDG to DOTA. Here's a large tumor in the pancreatic head. Note the absence of uptake on the FDG PET. The patient also has a liver metastasis here, which I will show you on the dotatate study in a minute. Notice that the FDG PET is negative in both of those regions, the primary tumor as well as the metastatic focus. In contrast, you can see the gallium dotatate study showing you avid uptake with the primary tumor as well as the liver metastasis, showing the contrast differences between FDG PET and dotatate study. In general, comparison to pentratide, DOTA peptides detect more lesions, smaller lesions, more occult tumors. They detect tumors with low to moderate expression of SSTR, lower radiation exposures. In one study, you can see that 95% of the lesions were detected, in contrast to 31% by the older agent, and 45% by conventional imaging, probably mostly CT scanning. So therapeutic decisions in this group of patients here changed by 33%. So it has also shown potential to diagnose primary tumors that are undetected by conventional methodology. This is just an illustration of example with both an incidental tumor showing DOTA uptake. There's a small tumor in the tail of the pancreas, hypervascular, with a small region of low density centrally. Here's the DOTA scan showing you very avid homogeneous uptake. This is a metastatic tumor, just showing you the different regions of uptake by DOTA. Also shown on MR, large infiltrating tumor here, multiple sites of metastatic disease. This is the contrast-enhanced gadolinium study. This is the diffusion-weighted scan correlating both DOTA as well as MR for detection of a tumor as well as the metastatic foci. Now, here's what's changing and has been changing for the last few years. Generally, tumors greater than 2 centimeters are considered surgical resection. Tumors obviously would show aggressive features like obstruction to the pancreatic duct, common bile duct, or have suspicious lymph nodes, are also to be considered for surgical resection. Some will consider even patients with metastatic disease for resection of primary tumor because primary tumor resection in some studies shows improvement in survival rates. You can see obviously the survival, 5-year survival rates go down drastically as you move down to stage 4, where it's only 35%. Stage 1, it's 100% in one series. What about surveillance? This is what's new for these patients. Only 6%, and the reason why surveillance is catching on, or at least in some centers, is that when people looked at surgical series, only 6% of 90 tumors in a small study, patients whose tumors were less than 2 centimeters, were actually malignant. So it's a small number. In another study looking at 77 patients with non-functioning tumors, where the mean tumor size was 1 centimeter, these patients were followed non-operatively for 45 months, and they showed no change in size or disease progression. So these things suggest to people maybe we should not be operating these. So there was one large meta-analysis done where 9 articles, and you can see it's only 344 patients, so it is not a large number of patients. It's still early going. So they compared sporadic tumors, that is incidentally detected tumors. Patients are asymptomatic, and you get a scan for some other reason like hematuria, and you pick up a small tumor. And they compared this to 64 patients with MEN-related PNETs. Tumor growth was observed in only 22% of the large sporadic group in comparison to 52% for the MEN-related group. Notice also the development of metastasis was 0 in this large group of sporadic patients. And some of them went on to surgical resection, and those were because they showed interval growth in size in the follow-up. But it was a small number. Here's one of those surveillance studies of patients who had short-term follow-up. The mean was about 18 months. Small size of tumor, 13 millimeters. You can see it ranged from up to 34 months total. Overall median growth over the short term was only 0.12 millimeters per year. In only 13%, tumor growth of 20% or greater was observed, and then a small group only underwent surgery. This was published in 2013. So the authors suggested that in a very select group of patients, non-operative management of asymptomatic, sporadic, small tumors may be safe. You can see they were very cautious in the terms that they used. And here's their study depicted in graphic form. Here's the size of the tumor, here's the follow-up, and you can see majority of these tumors are showing very slow interval growth or very small increments. But anything that started to shoot up, they operated. So basically any one of the red lines here went to surgery. So for example, this one grew up a little bit more, so they resected it. But many of the long ones you can see are being followed over a long period of time and showing no significant interval growth. So the controversy is still there, surveillance versus surgery. Several studies are supportive of non-operative management in select patients with less than 2 centimeters, but it has to look very benign appearing, meaning homogeneous enhancement, no duct obstruction, no suspicious nodes, etc. And they have to be asymptomatic. There are two contrary studies, two large registry studies showed improvement 5-year survival in patients who underwent surgery. They compared patients who didn't go surgery to patients who underwent surgery. And they showed that patients who underwent surgery had a much better survival rate, 72 and 82%, compared to the observation arm of 28 and 34%. And these are all in small tumors, so they argued that maybe we should be really operating. But there are a lot of reasons why these differences could be happening. In these two large registry studies, the reason for surveillance was not stated. Why were patients being surveyed? They don't say that. There were private insurers who were for the surgical patients. So basically, all the patients who underwent surgery had good surgical insurance coverage, so they got the operation. Some patients in this group were treated with chemotherapy, so those are not valid to be included. And also, they never stated how many of these patients were symptomatic or not. So there's a lot of cloud or muddiness to these two studies, and asymptomatic patients are probably underrepresented in these two cohorts. So there's a lot of doubts about this study, and so in many centers, people are moving to expected management of small asymptomatic, sporadic, non-functioning tumors. So it may be a reasonable option in highly selected patients. The current criteria for surveillance are CT and MRI features of low-grade tumor, meaning homogeneous, small tumor, incidentally detected. In some centers, confirmation with gallium-DOTA scans are essential to be included for surveillance. And in some centers, biopsy to establish the mitotic rate to make sure it is a low-grade tumor is absolutely mandatory. We have started to do this, but we are not demanding that the patients get a biopsy. So surgeons are leaning towards using just imaging criteria, which may or may not be a mistake. However, remember the level of evidence is quite low. We don't have like 10,000 patients or 1,000 patients, despite gathering information for 10 years. Studies are small, retrospective, patient selection for surveillance strategies still to be determined, so we will need much longer follow-up, but this is a trend that's catching on in many centers with not much data. Follow-up protocols, I'm not going to go into too much details, but basically these sporadic tumors that are not being operated get CT or MR every 6 months for 2 years, and then you follow annually, and then you have similar ones depending for the patients who have undergone surgery, depending on grade, how far you follow out, and then longer intervals for those who have grade 3 tumors. PET-CT is a plus minus in our own place. So I've covered the thing that's new. Now I'll just whip through the rest of these very, very fast to try and get you out on time. So there are multiple tumors which are in the functioning group. You see them all listed here. I'll just show you examples of the first 3 types. So the most common is the insulinoma. These are usually small tumors, solitary, mostly benign, mostly intrapancreatic in location. In MEN, there can be multiple. You know Whipple's triad, so I'm not going to spend time there. Here's a typical small exophytic neuroendocrine tumor here, an insulinoma in this patient on axial and sagittal reconstructed images. These can be mistaken for vessels, so look very carefully. This is a case given to me by Jeff Fiddler from the Mayo Clinic. You can see here's the arterial phase and the venous phase, and this lesion was missed at Mayo. Jeff told me to say that to you, but it was picked up in retrospect because the patient had functions. I'll show you the blow-up of where the lesion is. So that's the lesion. It was mistaken for a superior mesenteric vein, but in fact the superior mesenteric vein is over here. Oop. This structure is the superior mesenteric vein here, unopacified. Here's the superior mesenteric artery. This is the vein, but it was missed and thought this was the vein, but that's a small neuroendocrine tumor. So look very carefully at anything enhancing. if you're looking for these lesions. But they can be low density, so don't look only for hypervascular lesions. There's a low density insulinoma confirmed at surgery. Here's an MR showing you T2 bright signal homogeneous, heterogeneous enhancement on the arterial phase and portal venous phase images. Gastrinomas, these are second most common. Many of these are solitary and located in the duodenum, can be associated with Z syndrome, and can be multiple as well, usually small tumors, but they're malignant in large numbers of patients. Diagnosis is elevated gastrin with high basal acid output. They're usually located in the gastrinoma triangle, so that's where you should be looking for them. Here's a typical one on MR. You can see the lesion here in the gastric mucosa, the gastroduodenal junction. This patient already has a metastatic focus in a lymph node. So frequently, if you see multiple enhancing nodes around the pancreatic head, look for a small primary, because you're probably missing a small tumor in the duodenum or gastric wall. Here's another one given to me by Alec Megabo, a duodenal gastrinoma within the lumen, enhancing. Here's one less common, located in the pancreatic body, proximal body, with a metastatic focus in the right lobe of the liver. A gluconoma, the only reason I'm showing you this, sometimes you may see these patients with a rash, and they actually begin early on, much earlier before the tumor is detected. Most of the glucogonomas are large and metastatic at presentation. Serum glucagon levels are elevated. Here's one from the literature showing you the typical kind of rash called the erythema migrans. And this is not specific for this tumor, but it can occur there. Generally, these cutaneous symptoms begin 1 to 2 years before the diagnosis of glucogonoma is made. So sometimes you'll show this in an unknown case panel. Here's a glucogonoma with metastatic disease to the liver. The others, rare ones, are the vipomas and the somatostatinomas. I'm not going to show you examples of this, but basically there are the syndromes associated with them. Most of these are malignant tumors. We already talked about the association of syndromes, MEN1, von Hippel-Lindau neurofibromatosis. You can see there can be multiple types of tumors in the MEN types, non-functional to functioning. Same thing in von Hippel-Lindau. I'll just show you two examples. This is a patient with von Hippel-Lindau disease. Here's the renal cell carcinoma, multifocal, also has pancreatic cysts and incidental pancreatic cysts, which is the most common manifestation of pancreatic disease in patients with von Hippel-Lindau, but note also the hypervascular lesion in the head of the pancreas, a non-functioning tumor. And finally, there's a patient with von Hippel-Lindau with a non-functioning tumor in the head and uncinate process, as well as a pheochromocytoma. So what I've done is kind of given you a whirlwind run through neuroendocrine tumors, kind of focus more on the non-functioning tumors, which you're going to be seeing more in your practice. And I hope you find this helpful. Thank you very much.